Hi everyone, this is Dr. Medicine Alex, and in today's session we'll be discussing about cyclosporine. This video is being compiled from a more dermatological point of view, so I hope that it helps everyone. First of all, a brief introduction of about how cyclosporine came about. Cyclosporine was discovered when there was a quest for antifungals. It was first isolated from the soil fungus Tolypocladium inflatum gams. Its immunosuppressive properties came about, and it is now being used in various dermatoses as we know today. Its mechanism of action is that it is mainly a calcineurin inhibitor, which works by inhibiting mainly IL-2 production by lymphocytes. This IL-2 is inflammatory cytokine. It is a recruitory cytokine, and also there is inhibition of intracellular enzyme calcineurin by a complex which is found between cyclosporine and cyclophilin, which results in the further reduction of NFKB, and as a result multiple cytokines such as IL-2, TNF alpha, IL-8, interferon gamma, and adhesion molecules such as ICAM1 are all reduced, finally leading to a decreased lymphocytic infiltration, inflammation, and recruitment. Indications from a dermatological point of view, there are two main indications. These have been FDA approved, US FDA approved. These are psoriasis and atopic dermatitis. And also in psoriasis, we do not use it as a first line of management, mostly in severe and recalcitrant cases. There are other implications which in where we use cyclosporine in very later stages whenever the disease is not responding to the usual treatment, as in some bullous disorders such as pemphigus, and then autoimmune conditions such as SLE, scleroderma, alopecia areata, and then we have acneic dermatitis, some neutrophic dermatosis such as Behcet's disease and pyoderma gangrenosum, and also in urticaria, which is chronic and spontaneous. Coming to contraindications, we can divide them into two categories, but in usual clinical practice, anything and everything is taken really care of, and sometimes there can be a slight blurring of the line between absolute and relative contraindications. But most importantly, cyclosporine is a very nephrotoxic drug, so any patient who has a compromised renal function and has uncontrolled hypertension is an absolute contraindication for the usage of disease. Some may say that hypertension which is under control or the patient is on medication, in them we can use a drug, but usually in clinical practice there is a lot of care to be taken while giving cyclosporine in these patients. Other absolute contraindications such as include hypersensitivity towards this drug, and in case of malignancies such as cutaneous T cell lymphomas, or if the patient has persistent malignancy, then cyclosporine is not given. Relative contraindications, these can be in patients who are not in the age group of 18 to 64 years, that is patients who are less than 18 years or more than 64 years of age, and in patients who are on medications that can interfere with cyclosporine metabolism, essentially contributing to its toxicity, and then immunodeficient patients, in patients who have active infection, who have taken concurrent live attenuated vaccination, or in patients who are on other medications that are nephrotoxic such as macrolides or azole antifungals and antivirals, and in pregnant and lactating patients. Sometimes unreliable patients who are not willing for regular follow-up or regular monitoring are also not given cyclosporine. Coming to its adverse effects, there are two main adverse effects that are taken like great care of while giving cyclosporine. First one is nephrotoxicity and the other is hypertension. Nephrotoxicity, its mechanism can be because there is impairment in glomerular filtration, which gets back usually after we stop giving cyclosporine, and sometimes cyclosporine can also cause interstitial fibrosis, which is irreversible and can further contribute to hypertension and nephrotoxicity even after the drug has been stopped. Then in persons who have hypertension, we all know that cyclosporine is contraindicated. Why? Because the hypertension, it can occur by reversible mechanisms and also by irreversible mechanisms. So once you stop the drug, hypertension may resolve, but it is not always the case. So Cyclosporine can have a direct vasoconstrictive effect on the smooth muscles on vascular smooth muscles of the kidneys, and it can also cause renal dysfunction, which further contribute to hypertension. This hypertension, it is usually managed by calcium channel inhibitors, such as nifedipine and isradipine. We don't necessarily use verapamil and diltiazem because they can further affect the serum levels of cyclosporine. And enzyme inhibitors such as ACEIs and ARBs are to be avoided because they further cause electrolyte imbalance, which is usually also caused by cyclosporine in the first place. So there is increased risk of hyperkalemia. Then hyperlipidemia is also another side effect. Usually we can manage this by using dietary modifications or lipid lowering agents, or by monitoring the patient and reducing the dosage when it is needed. Other side effects, we can also look for gastrointestinal side effects, or they can be headaches, paresthesias and tremors, gingival hyperplasia, hypertrichosis, and there can be electrolyte disturbances such as hyperkalemia, hypomagnesemia, and hyperuricemia. There is an increased risk of malignancy such as non-melanoma skin cancers, mostly like squamous cell carcinoma. There can be increased risk of lymphomas, which usually requires monitoring in predisposed patients. Coming to dosage, the maximum dosage that is acceptable is 5 mg per kg per day, but the starting dose, it depends on the type of disease. For psoriasis, we start with 2 to 3 mg per kg per day, but as the disease, we see the response, and if the disease responds, we can do the tapering of the dosage. But if it is not responding, then we have to do increments of 0.5 to 1 mg per kg per day, depending upon how well the disease is responding and not responding. The maximum dosage again we can reach is only 5 mg per kg per day, and if there's no response after 3 months, then the drug is to be discontinued. In case of other conditions such as atopic dermatitis or urticaria, we can start with a similar starting dose, that is 2 to 3 mg per kg per day. Next, monitoring. This is a very important aspect, as cyclosporine as a drug shouldn't be taken lightly. So before starting, we have to do some baseline investigations, such as taking the complete history of the patient, their physical examination, and recording their blood pressure first, so as to detect if the patient is already hypertensive or not. And then for renal functions, we have to do serum creatinine levels. We have to take at least 2 baseline creatinine levels a day apart. And then there is a requirement for liver function tests, doing lipid profiles, and doing complete blood picture. I have written complete blood picture at the end, but it is the usual first investigation that we do. But depending upon the importance, it is the serum creatinine level that should be taken into consideration the first. Coming to follow-up, at each visit, the patient's blood pressure should be checked, and we have to reevaluate the patient every 2 weeks for the first 1 to 2 months, and later on we can do the evaluation for every 4 to 6 weeks. There is a need for doing renal function tests every 2 weeks for the first 2 months, and then monthly while the patient is on cyclosporine. All in all, renal functional monitoring is important. So if the patient's creatinine rises by 30% from baseline dose, it is to be reduced. That is, dose tapering is required, and it should be maintained so for 1 month. In worst case scenarios, there might also be need to stopping the drug if the patient has a worsening in serum creatinine levels. However, it can be reintroduced if the creatinine value is within 10% of the baseline. Thank you.